I think we are going to go ahead and get started. So I want to thank everyone for joining us today. This is our first virtual KCQVIC forum. So we're excited to have these and be able to continue this in the ways that we can during COVID. So thank you all for your patience as we learn how to navigate this all together. But my name is Stacy Farr, and I am one of the facilitators of the Kansas City Quality and Value Innovation Consortium. Today's a really exciting session. We're learning about the role of first responders and police in healthcare, and we have a great agenda, as you can all see up, and we're excited to go through that today. So some of you may be new to hearing about what the QVIC is, so we just wanted to give a very quick background and introduction to the QVIC before we go into the speakers. And I also do want to say that, if you have questions that arise during any of the presentation, feel free to use the chat box, and we'll be monitoring that, and we can discuss those questions during the Q&A portion, which is at 4:40, and that can be for any of the speakers at all. So we do want to save the questions for the speakers until after they've finished presenting and we're actually in the Q&A. So just kind of wanted to give everyone a heads up on those logistics, and also that everyone is muted, but also when we do get to the Q&A, if you have a question you'd rather ask aloud, we can also do that at that time. So just wanted to let everyone know that. With that, I guess I will jump in. So you can see our agenda here. So to tell you a little bit, just high level about what the QVIC is. So the Quality and Value Innovation Consortium, which started in 2018, and with a vision really to bring multiple stakeholders together to improve the quality and value of healthcare. And we have a number of partners, as you can see here on the slide, that are part of making that happen. And our goal really is to create a multi-stakeholder collaborative to improve the quality and value of healthcare and build a foundation for translating knowledge into practice. We also want to assist the regional hospitals with them improving their value in this shifting landscape that we're dealing with in terms of how we pay for things in healthcare. So it consists right now, the facilitators of the QVIC include myself. I'm a health services researcher by training, and I've worked on federal implementation and evaluations, and Dr. Carol Decker, who's a qualitative nurse researcher, as well as Dr. John Spertus, who is a nationally recognized expert in outcomes research. And so the three of us started out by, well, I guess here a little more background. I should get into that first. So everyone kind of is aware, that the US is really struggling with how we transition from fee-for-service into a value-based healthcare environment. And so we want to kind of help with that transition. And in doing so, we need to work with a number of different stakeholders. We're working with the hospital systems in terms of leadership, quality improvement, people that work on the specific aspects that are the projects we'll be working on in those strategic initiatives. We're also working with healthcare providers and researchers who are either focused on a specific topic area, otherwise also and included implementation science, quality improvement, health outcomes, health economics and value, as well as purchasers, patients, and community-based organizations. And go through a high-level vision of how the QVIC works is we have our hospitals and we have researchers, and then with the hospitals, they're identifying really the clinical champions who will be working with us on these different regional quality improvement initiatives. And then the researchers, we find those committed experts as well. And they are, and working with, they work together with an advisory board, content experts, community resources, and payers, and really kind of design these interventions for implementation and the metrics for measurement. And then our researchers will be and are work on the customized implementation with each of the hospitals on those interventions, as well as the measurement of the outcomes and feedback to refine the interventions as we need to. And in terms of how do we pick these projects, right? So how we did this is we started out in 2018 and we kind of did a tour of a lot of the Kansas City stakeholders and hospitals. And we went out to all of the stakeholders and wanted to understand from them what their strategic priorities were and what they were most interested in focusing on. so that we could align our interventions and our things that we want to do with the hospitals with the things that are important to them, right? Which makes sense. And so we met with over 200 people in 2018 and 2019, a lot of hospital leadership, payers, hospital associations, state and local health departments, community-based organizations, and researchers. And we compiled a list of topics. This is a fun little word cloud here of a lot of the different topics that kind of rose to the top of being high priority for our stakeholders in our region. And there was a lot. And so through a number of processes that I'm not going to cover today, we narrowed that down to 2 different topics for regional implementation across multiple hospitals. And sorry, I'm just going to make sure I'm uncheck checkbox. Okay. Okay, and so we settled on these 2 regional projects. Our first one is opioid management, and that is a project you're going to hear actually a little more about today from Jonathan Bose, but we're working with the Missouri Hospital Association and all of their different partners on helping enhance the implementation of KC EPIC, which is engaging patients in care coordination, as well as the measurement of the outcomes of that. And then our second regional project is Transitions of Care for Heart Failure. And with this project, we're focusing on a suite of interventions to help the hospitals kind of break the cycle of readmissions for heart failure, as well as trying to improve the outcomes and patient experience with having that condition. And so we have a number of different interventions and working with different hospitals on that. Clearly, and I think something I should just note is that right now, these are not the highest priority topics for the hospitals. As we're all aware, we're dealing with a pandemic. And so, we are working on the things that we can do to help the hospitals with these things right now, because it's obviously still a priority, but, things are a little different right now. And, we will pivot as we need to.
Stacy, this is Carol. Oh, I don't mean to interrupt, but your slides have disappeared.
Oh, they have. I see it says not sharing anymore. Host disabled participant screen sharing.
I just sent you a chat.
Okay.
Shaylee, try again. Try and share again. Will it still not let you?
It still says host disabled.
Well, that's odd. I didn't change anything.
Share screen. Host disabled participant screen sharing.
Okay, let me I'm going to mute myself and jump into the Zoom settings real quick. If you want to keep talking, you can.
Okay.
I'll be right back.
Sure. Well, in the interest of that, you can't see the agenda right now of the future sessions, but we can share that via email to anyone who registered for this today. But the next slide really shows, it's kind of a layout of by month what all of our different topics are that we'll be covering for the remainder of 2020 in the KCQVIC forum. And so what we did is we really took all those topics that are of high interest and priority to hospital systems and other stakeholders, and we are developing these monthly forums. This one is one of them, so the role of police and first responders in healthcare. And
Stacey, you should be good to go again.
Thanks. Awesome. Share. There we go. Right, everyone can see me? Any thumbs up? I'm looking on a video. Anyone?
Yes. Yep,
okay.
You're good.
Thank you. And so, so we took these topics and we are covering these. And so basically stay tuned. You can register the same way you registered for today for any of these future ones. And I'll move along here. And so that brings me to, back to our agenda, and I would love to turn it over to our next presenter. And who that is, let me introduce. So we're really fortunate today to have a great number of speakers on this topic. I think it's just a really timely topic as well, because, not only is there a change in how police and EMS are working with hospitals due to COVID, but, there's just so many different avenues of the way in which they are working with individuals and healthcare and hospitals in terms of mental health and addiction and substance abuse and domestic violence and crime. And I just think, this will be a really interesting session today. So we're looking forward to it. And our first speaker today is providing a police perspective. And so this is the mental illness revolving door, a problem for police, hospitals, and healthcare. And we have Sergeant Sean Hess with Kansas City, Missouri Police Department and supervisor for the KCPD Crisis Intervention Team Unit. And looking on the list of participants, is Sergeant Hess on? So I'll let you unmute yourself and share your screen. I'm scrolling, I'm looking. Okay, or maybe he's not on yet. So, all right, well, change of plans. We will move on to our next speaker in our lineup. So, and we can always circle back and switch. So if it's okay, Jonathan, we'll move on to you, providing our community care provider perspective, which is EPIC and KC. And so Jonathan Bose is an EPIC program manager, as well as a licensed addiction counselor with ComCare. So the floor is yours, Jonathan.
Thank you. And yeah, thanks for having me. I do have a few slides if I'm able to share my screen. It's not a big deal if I'm not, but looks like that should work. So some of these I'll skip over just because it's kind of built for a different community. So I won't belabor too many points that aren't relevant to today, but just to give you guys a brief overview of what EPIC is. So EPIC is a kind of a statewide program that is spearheaded by Department of Mental Health as well as Missouri Hospital Association, and they're kind of building it in sections. So St. Louis started nearly 4 years ago now, I believe, maybe 4 years ago at this point, providing care coordination for individuals who had shown up at the local emergency departments with overdoses, opioid overdoses. So Kansas City started right at a year ago, about 13 months ago. And so I still like to say we're babies, but we're definitely running hard here. So this just kind of gives a brief overview of what EPIC is, the mission, and the purpose behind it. And it won't have a lot of stats about what we're actually doing in terms of numbers, but I can certainly answer those maybe at the Q&A if anybody needs to hear that. And if I can get my thing to work. So I'm going to try to present here. There we go. So just the mission of ComCare. ComCare is a behavioral health management organization. We work in collaboration with community mental health centers to provide access to affordable, high quality, effective behavioral health services. And so how we kind of got connected to EPIC with ComCare is just the continued rising overdose in Missouri. For opioid overdoses, Missouri regularly lands in the top kind of quadrant of the nation in opioid overdoses. And while other states have kind of tailed off or leveled off, Missouri has continued to rise based on as many numbers we can get anyway. So heroin users oftentimes report that their addictions begin with prescription drugs. 43% of hospital patients with overdoses in 2016 had previous hospital utilization for prescription opioid abuse. So these people they're going to the hospital multiple times for similar opioid abuse problems and not necessarily getting more or better connected to services and recovery oriented care. So EPIC kind of hopefully is filling that gap a little bit, a lot of it actually. So drug overdose death rates are higher than the national average. Nearly 3 Missourians a day die from opioid overdose. As of 2016, there may be some newer numbers out there now, but at the time I was looking, 2016 were some of the most recent data that we'd had. So what is EPIC? EPIC stands for Engaging Patients in Care Coordination. And so we're designed to offer 24/7 linkage to services. We have 6 peer specialists, also known as recovery coaches. They're all hired by ComCare to meet individuals in the emergency departments who are identified by hospital staff. And I'll talk briefly about how it relates to today's topic, is we are also working to expand from local emergency departments to also engaging with our first responders. So we're working with other community partners right now, including a kind of, again, a statewide initiative labeled as DOTS. And I'm not going to remember the acronym for DOTS, but essentially they're working with first responders to help provide overdose education and safe handling of overdose cases. And so EPIC's coming alongside them, trying to get connected with local, whether that's police departments, fire, and EMS, so that when first responders respond to overdose situations, and maybe the client eventually gets revived and refuses medical transport, EPIC can still get involved and do all these other things that we'll talk about doing. So as we get patients and referrals, those clients then get access to a recovery coach for the next 6 to 12 months. And we help connect them to recovery services, medication-assisted treatment, treatment programming, recovery housing, all sorts of different things. So our target population is anybody over the age of 16 in Kansas City, obviously opioid overdose or anything. We also label overdose not just as in sense of medical overdose, but really anybody who is overdosing on opioids. So if somebody's always taking 3 extra pills, they might be in a higher risk zone. And so maybe they don't need the same level of treatment as someone who's maybe using illicit street drugs, but they would still probably benefit from having a recovery coach at least talk to them and share with them some ideas. So we also help individuals who just have, who maybe not medically overdose, but have severe maybe opioid use disorder. We serve the Western region, but right now we're primarily in Jackson, Clay, I always mess up, Clay, Platte, and Rice counties, I think, or Clay, Platte, and Ray. I always forget which 3 it is, the Tri-County region. And then just want them to be open to meeting with a recovery coach is all. So we do have some area partners that we work with directly, the local mental health and recovery centers in the area in Jackson County. And again, there you go, you got Platte, Clay, and Ray County there. We don't go out to all those other regions right now just because of time constraints, and the ability to connect with people in further out regions would be much more challenging. So we do work closely with Tri-County, Rediscover, Truman Behavioral Health, Comprehensive SWOPE, and Heartland Treatment to help connect residents to those facilities. We do this level of project data capture, so you can kind of see there. We obviously have a referral and initial contact form that kind of come in that first day, that first visit we have with them. And we do a 14, 30, 90, and 180-day follow-up form. So 2-week, 1 month, 3 month, and 6 month follow-up form. And that's our data capture points. Obviously, along those lines, we're checking in with the client, checking in with treatment providers, making sure everyone is connected to services. And then this might be kind of the last major slide I definitely want to share, and then I'll maybe check with time and see if I need to talk more. But here's our goals, obviously, is to improve client recovery ambivalence. So for those clients who are maybe struggling, you know, they're on the fence, like, yeah, no, I don't like feeling this way, but I don't know what else to do. So hopefully with a recovery coach, they can help resolve some of that. Increase the substance use and MAT access. So sometimes it's just hard to find those services, and sometimes it's really easy. And we want to make it easier for sure. So we're trying to increase access to treatment and medication for addiction treatment. And we also provide overdose education to each patient we come along with, even if they don't take our services, even if we talk to them and they're like, yeah, thanks, but no thanks. We still do provide that overdose education just to help reduce the harm that may be being done by their substance use. And then Narcan distribution as well. And there are certainly some challenges to Narcan distribution, which we can get into if we want to, but we do provide Narcan to anyone who wants it and have it available. Obviously, an increase in medication for addiction treatment inductions. Our goal is to increase those happening in the emergency departments. Right now, many doctors don't do them. And so that is one of our goals, though, is to encourage doctors and provide information where necessary. And then overall goal of EPIC is to increase medical staff willing to provide long-term MAT services. Outcomes, obviously, willingness to engage in recovery, connection to treatment from the ED. We want to increase and have a obviously high percentage of number of our clients who receive overdose education and Narcan distribution. Substance treatment retention is a big part of our goal, as well as medication for addiction treatment. And again, these are kind of related to the emergency department because that's where we kind of started our program in relation to today's discussion about police and healthcare and first responders and healthcare. All these titles or all these sections that speak about the emergency department can easily be replaced with things such as first responders or law enforcement in healthcare. So that is not too far. Am I good on time, or shall we? I don't want to. I know we are all pinched on time and want to keep it on track. So
maybe another minute or two.
Yeah, that would be fine. So I'll just speak briefly about just the role of our coaches, just so we can all be aware of that. So our recovery coaches all have lived experience, and they are also all certified peer specialists through the state of Missouri. So that just indicates they have they go through like a 40-hour orientation and training that's pretty intensive in terms of what peer supports look like, in terms of just the ethical, the boundaries related to it, services that can be provided around it. And so our goal is to outreach and build relationships with hospitals. Our recovery coach play a huge role in that. As much as I'd like to take credit for some of the relationships we have, our coaches are the ones doing so much of that outreach because they're at the hospital and they're meeting with clients and patients, and then they're meeting with the doctors and the nurses. Obviously, we assist in referrals to area partners and connecting people to treatment and connecting people to care. And they don't have that lonely gap between the hospital and treatment. And now they have a coach to walk with them through those processes. And in that vein, we help mitigate barriers to initial engagement. We work hard. Our coaches are constantly advocating for patients' care and services, connecting partners to doctors so that maybe hospital staff can talk to treatment providers, which then allows a smoother transition to treatment. We already mentioned the overdose education, Narcan distribution, and the outcomes data collection. So we'll leave it at that for now. And again, we can circle back around if anybody has questions during our Q&A time.
Great. Thank you very much, Jonathan. Awesome. Okay. Well, in the interest of time, I'm going to jump right into our next speaker. So we do have Sergeant Hess on now. So I apologize. We had some mixed passwords being sent around. So we now have Sergeant Sean Hess, who's with the Kansas City, Missouri Police Department and supervisor for the KCPD Crisis Intervention Team Unit, who's going to give us a police perspective on this, specifically the mental illness revolving door, a problem for police, hospitals, and healthcare. And we're very much looking forward to hearing from you. So the floor is yours, Sean.
Good afternoon. Can you hear me okay?
Yep.
Good. All right. Well, I'm going to download my, hopefully this will work, my PowerPoint here. All right. Okay. Are we on with the PowerPoint, I hope? All right. So like Stacy said, my name's Sean Hess. I'm a sergeant with the Kansas City, Missouri Police Department, and I'm the supervisor for the Crisis Intervention Team, or CIT unit, for Kansas City. So I want to kind of jump right into it. My presentation today is mainly going to cover, what our interaction is in law enforcement with for other first responders, and that being fire, EMS, and hospital EDs. But I do want to first touch real briefly on what is CIT. Kind of give you just a little background on that. So Crisis Intervention Team training is basically 40 hours of specialized training for law enforcement officers to better interact with somebody in a mental health crisis situation. We've had this training in Kansas City for almost 20 years now, and CIT is really geared for the district officers, the one out there handling the calls. De-escalation is really emphasized, slowing down, time, distance, and also to think maybe about using other alternatives such as services, hospitals rather than jail. We're very effective at this. We have about 55% of all KCPD that have been trained, and oops, I had a meltdown here on the computer. About 55% of all KCPD are trained. We've expanded the training to be.
Sergeant Hess, can I interrupt 1 sec?
Sure.
I'm not sure we can only see a portion of your slide. I'm not sure.
Uh-oh. Let me see here.
I'm not sure if you know what a quick solution on
No.
I'm not a techie, so I don't, but.
No, obviously I'm not either, so I don't know.
Oh.
Is that helping?
I mean, that works.
Maybe.
Does it work when you touch the bottom where it says presenter? Do you know let's see if you scroll down a little bit.
Slide share.
Yeah, that one. Does that one work?
Okay, I'm going back to.
Oh, and then we go back to just a portion of the slide.
Well, we could do this.
Okay.
If you can see that, that's fine.
Yes, thank you. Sorry about that.
No worries. Yeah, the COVID-19 restrictions are presenting some unique challenges for us. I tell you, I've never thought that, but yeah. So let me see here. So we offer some advanced classes now as well with youth, advanced CIT vets, and telecommunications. Just kind of getting an over idea of what CIT is. My unit is 4 officers that basically do CIT full time. We do the training, the presentations, and really kind of hammer out the most chronic, the most dangerous, and for themselves and others in the community. And so that's kind of the job that we do. I want to kind of get into what the issues are, and that is today with the cut in services and the lack of one area that we could take somebody to. Today, really, we're kind of forced into being what I call a sidewalk psychiatrist. So you see nationally, 10 to 16% of all calls have to do with somebody in mental health crisis. Kansas City, it's about 20 to 30%. And it's a huge impact on the officers and the community, if you want to think about that, the numbers on that. So it really impacts us. And so it causes some issues. If you're in crisis in Kansas City, a good chance is that you're going to end up in an ambulance going to an emergency room. And the ERs are overtaxed. It's really just not an ideal situation at all. And you can see how many on the 117 million people were last year, according to the New York Times. And I can vouch that it's just just continuous people going in and out of the hospitals. We often call that the revolving door in Kansas City. You get somebody that's in a crisis situation, you have police contact, more likely EMS and fire respond to the scene. Sometimes you may go to jail, but most often you're going to end up in the ED. And then there you'll maybe rotate back out to the streets, and this cycle repeats itself over and over again. We don't have a finite number of resources in the area, and it really taxes the police, the EMS, fire, and the emergency rooms. And we're finding out that some of the top utilizers of services almost go every day to the hospital. And when people really need to go to the services, a lot of times they're full because of these chronic users of the system. So a lot of our impact has been to how do we decrease this? What are some of the options that we can do and partner with our other community resources in dealing with a lot of these what we call high utilizers of services, because most of the time they're not the high crime, as far as you think of the felony or anything like that. They're usually loitering, trespassing, drinking in public, urinating in public, some of the low rent types on that. And so it's very challenging to get these people into services and to break this cycle. Housing, a lot of times they're really resilient to the housing. And that's where my officers come in, because we do what I call hot teams, is homeless outreach. And that's what we really try to engage and get them into housing, because that's a lot of the times the first step to breaking this cycle. We coordinate with the EDs. We just started getting emergency room nurses into our training earlier last year, and was very successful. North Kansas City was the first emergency room to partner with us in this CIT training, and it's already paid off with them identifying some other alternatives, high-end utilizers, and some things that we could do differently to break that cycle. We work with fire, EMS as well, and like I said, a lot of it's just coordination. There's some exciting things that we're working with hospital diversion or emergency room diversion throughout the state of Missouri. We work very closely with community mental health liaisons from each of the area community providers, such as SWOPE, Rediscover, Tri-County, TMC, and Comprehensive, and the VA as well. And it's important to try to break these cycles to get them out of that revolving door and into other services. So, I mean, this is just kind of a real brief. We want to break that revolving door, develop alternative plans to see that if we could do that. Housing is, like I said, is a huge first step on that, and coordination and working. The city is working on trying to develop some software and some information that they'll be able to hopefully put into place and work and identify this and then get them out of this wheelhouse. It's a tough situation, one that doesn't have any easy answers other than a lot of money, and we don't seem to have that. But it's getting the partnerships, identifying the people, and working with them, and then the other, like Department of Health and Senior Services, if it's a guardianship or something like that we need to try to work with and interact with. So it's just a lot of different things that we have that we're trying to partner with and work with. They're outside the norm that you usually think of as law enforcement on that. So it's just some of the things that we're trying to put into play to break that wheel out on that revolving door. So I don't know if we have any other time. The COVID-19 really is kind of brought to the forefront of that. There's no place to take a lot of these people. The jail is obviously not a good situation, and so we're really just kind of spinning our wheels a lot with some of these folks and going in and out, and it's kind of disheartening, I think, overall on that. So I think I froze maybe. Oh, you get me, Stacy, or?
Oh, yep, I can hear you and
Okay.
Yep.
Kind of frozen on the video. All right, well, I think that's almost my time there.
Okay.
We'll wait for questions and stuff at the end, whatever you need.
Great. Wonderful. Yes, thank you. Yeah, we'll save any questions. Anyone can put them in the chat box, or you can, we'll save them for the Q&A portion. But thank you, Sergeant Hess. So now we're going to move on to our next perspective. We have both an emergency medical services and researcher partnership perspective. So this is research in the pre-hospital realm. And so we have two presenters who will be kind of sharing together. We have Dr. Erica Carney, who's the medical director with the Kansas City Fire Department, as well as Dr. Monica Gaddis, who is associate professor at UMKC in the School of Medicine and research director with the Department of Emergency Medicine for Truman Medical Center and UMKC. So we will let you guys share your screen and talk now.
All right, can you guys hear me okay?
Yes.
All right, let me try to share screen.
Sergeant Hess, you'll have to stop sharing your screen.
By the way, Sergeant Hess, it's really good to see you. I'm glad you're healthy in the midst of all of this. Him and I are on multiple committees together. So, all right, let me get my screen. There we go. Can you guys see that? Okay, and if I go to my main slideshow, is it cut off or can you see the slides?
We can see the whole thing.
Okay, so I'm also going to introduce my chief oversight paramedic, Michelle Shearer, who's also on this call as well. So between Michelle and myself, we do medical oversight for all of Kansas City, Missouri, which is KCFD. I'm also an ER doc at Truman Medical Center, which is where we work very closely with Dr. Monica Gaddis. So just real brief introduction into research in the pre-hospital realm. Why do we want to research in the pre-hospital realm? COVID is the perfect example of this. EMS touches every single hospital. We go into every single nursing home. And then as I had said previously, we deliver those patients into the hospital. It's unprecedented times, and EMS is very used to things being unprecedented. We are used to dealing in the public health realm, the public safety realm, and the healthcare realm. And so EMS is very adaptable, especially in these specific instances. It also improves direct patient care. As a medical director, creating protocols for my pre-hospital personnel, it's best done on outcomes. So if the hospitals can share those outcomes with me, then I can improve my protocols when we are directing the medics on what they can and can't do for taking care of patients. An example of this too is, for instance, most out-of-hospital cardiac arrests occur at home. So most people are going to die at home. So why is that? Maybe we should study that, ask that question. It includes direct knowledge gain. So when we use epinephrine in cardiac arrest, for instance, that all came out of pre-hospital research, and the ability of epinephrine to get a heartbeat back, yes or no. This is all EMS-based research. We're also very big in trauma. As you guys know, that's our bread and butter in the pre-hospital realm. And so most trauma surgeons look to us when asking questions and introducing interventions into their own protocols and treatment. And it's the teamwork. We are part of the patient care. We are part of the continuum of care. When strokes, heart attacks, traumas occur, we are the first responder that is there. So it's important to include us in the entire healthcare research bank. So we are also very ripe with data. We have data all over. We have state registries, we have regional registries, we have our own electronic health records. So just real quick, our cardiac arrest registry, it's nationally known, and it has different criteria that we input to say how somebody dies. Was bystander intervention given? That's ripe for research. We have state trauma registries that all of the trauma centers have to enter into through the hospitals. I saw Denise Smog on here. She's probably going to talk about that. We have our patient safety organization database in our department, but also the state database that we submit to. NMSIS is another national emergency medicine information system that our state uses. They're on NMSIS 3. Pediatric related research, of course, is a huge cache of information. We're also unique in the public safety sector, and Sergeant Hess kind of touched on this a little bit. We look a lot into economics and cost analyses as well, which is a little bit different than the typical healthcare perspective. Here in our region, we have what's known as EM Resource. So in Corona times, for instance, as a medical director, I can log into EM Resource and see how many Corona patients there are in our region. It's by state. It's here in Kansas City, Missouri, but also on the Kansas side. And EMS has been very used to sharing that data with the hospital. So we know if your hospital is open or closed, can you take certain patients? And so again, we're very used to collecting data and sharing that data. To speak a little bit more about our agency and our city specifically is the Chief Oversight Paramedic, Michelle Shear. She is in charge of communicating between the fire department and me, basically. Michelle, are you on here?
Yes, I'm here.
All right. Do you want to say just a little bit about what you do in the office and the data that you look at just as part of the job?
I look at our cardiac arrest data and airway or advanced airway placements, whether it's endotracheal intubation or the iGel. I'm also looking at medication administration, compliance on different protocols, that sort of thing. And I'm able to, the charting system that we're using, ESO, it gathers so much data that we're able to really produce, do a lot of rich data mining off of the reports that the paramedics write.
Yeah. So as a system and a specialty in EMS, we are very used to running off of quality improvement. And so I can, as the medical director, go to Michelle and say, what did our cardiac arrest outcomes look like last month? What did they look like compared to the national? What did our aspirin given in chest pain protocols look like in the compliance with that percentage? So historically, we have a bunch of residents who create, resident physicians in the emergency department who create research studies based off of our rich data banks. So being pre-hospital, though, we do have challenges, especially when it comes to research. Overall, we have a very non-experimental approach to how we take care of patients. You call and you're in the back alley, we've got to take care of you in the back alley. It's a very uncontrolled environment. We don't get to create a sterile environment that's easily reproducible between calls. And so that is a limitation. We also function with surrogate settings. So if we cannot directly intervene in patient care, a lot of times we will use skills or simulations. So a simulated study is a little bit different than a live patient. It is a huge, complex, interrelated job being in public safety. So not only do we deal with the trauma surgeons at my home shop at Truman, we deal with the trauma surgeons at every single trauma center, level 1 all the way down, same with strokes and heart attacks. And so if a trauma surgeon comes to us and wants a certain protocol, we have to approach the region with that and make sure that it works for every single hospital. So when it comes to a specific study setting, sometimes that can be a limitation because, again, there's multiple different facilities involved in what we do and in a non-controlled environment. There's a culture with not sharing information with EMS providers. That culture is changing, especially in times of Corona. And Corona, because of Corona, the state statute was waived that says if we transported a Corona positive patient to a hospital, now you can tell us that patient's information. Pre-Corona, it would be a big battle if Michelle, as a paramedic, is out in the field and gets stuck by a needle and or is just inquiring about a patient's outcome. Hey, that trauma that I ran to Truman, how did they do? It would be a big battle for her to get that information because of the misunderstanding of EMS being the beginning of the patient care. Again, that is starting to change though, and we're starting to see increased communication between the hospital and pre-hospital, and Corona has helped out with that. So I've kind of talked about that bullet point. And then being in public safety, which Sergeant Hess is very well aware of, there's a lot of politics. And so for me to make a decision or to start a study, it has to go through multiple committees. A lot of these committees involve city council. Some of them involve trust or the mayor. And so we have to be able to ask these questions in an environment that we have to answer specific questions that are not normal to a healthcare setting usually. Dr. Gaddis is going to talk about the most important part of this presentation. What does all this mean? What are we focusing on currently? And how this is being used, this relationship here in Corona times.
Okay, can you guys hear me? Okay, perfect. I've got lawnmowers out there in the neighbor's yard, so hopefully I put on my headset. Okay, so there were a lot of...
there's a lot of lawn mowing on that beautiful lake you're sitting on.
Yeah, I'm in Montenegro right now. It's my virtual traveling to make me feel better during all of this quarantining. So with all these challenges that Dr. Carney just explained, we have had a lot of research successes in EMS also. And so I'm going to go over some of our research that we have been doing that's ongoing and that is in the past. So EMS research is a hot topic right now. If you get in and you start reading the medical literature, you see a lot of this. And it's very, very important because our EMS partners actually set the stage for what happens in the emergency department. And they basically have a lot to say and do about the outcome of the patient. So one of the areas that we have looked at are protocols. Now, EMS providers have to follow protocols or try to follow protocols so that they provide standardized treatment for the patients in the field. It's always nice to look at those protocols because number one, you don't want to overburden the EMS provider, but at the same time, you don't want to provide them with not enough direction. And they need to let us know if these protocols are working, if they're too much, if they're too little. So we've done some interesting studies on protocols that have resulted in rewriting protocols because they're just too extensive. Mass casualty incidents. Before COVID, this was the hot topic. One thing that we did, we had a little resident about 2 years ago who was really interested in knowing whether or not the people at Truman were prepared for a mass casualty incident and if they even knew their own mass casualty policies. So he did this very, very simple survey, surveying the medical providers. And it was very interesting because he found that maybe we need to do a little bit more training, and maybe we need to find a little bit more information. This went to the National Association of EMS Physicians meeting, and it definitely made an impact. So now I just had a resident complete a study looking at feelings about, or not feelings, how people feel prepared for mass casualty incidents in the field. So a local area EMS provider, fire department, took the survey, and that was very interesting. Improve care through teamwork between EMS and transport hospitals. That's another interesting area. Right now we have a study in the works that will go on board after COVID, I'm sure, looking at how we transfer patients from EMS to the hospitals, and how much information is sent through. Is there a standardized way to transfer these patients and get information across to the doctors from the EMS providers? Another one is high utilizers. We can actually use Michelle Scherer's database to identify high utilizers. From there, we can reconnect to the electronic medical record at Truman, identify them and look at their outcomes, look at why they were transported in the first place, and then from there do some education and some outreach to try to figure out how to deal with these very high utilizers. And then finally, we have a new study that's starting up soon. I'm in the process now of writing the IRB application along with input from my colleagues on this study team, looking at antibodies and antigen testing in the EMS and fire department in Kansas City, Missouri. We're hoping to start this as soon as possible once we identify where we can get our tests from. And thankfully it was funded, and we are moving forward with that study. It's ultimately, it will help the fire department know how to handle going back to work and how to remove people from the field and how they test. So that's basically as many research successes as we've had a lot more, but these are the big ones that I thought you guys would all be interested in. Residents love EMS research. We have to beat them off with a stick sometimes because there's so many projects that they want to do and come to us with.
I think it's because we're so cool, Dr. Gaddis.
Gotta be.
So a quick extrapolation, because I see we have a couple of minutes left, and then I'll go to I had a question slide, but we'll save that for the end. On the EMS protocol that Dr. Gaddis was talking about in regards to mass casualty incidents and the knowledge that the physicians had, these were attending level physicians. This wasn't the medical students saying, hey, do you know where to put a green patient? Do you know where to put a red patient? This was the attending level physicians who were uncomfortable with the hospital's policy. So what that put into motion is we've got to write a policy that mirrors what actually happens in an MCI. So for instance, an MCI nowadays, Sergeant Hess will know way better than I will, is probably going to be penetrating trauma, active shooters. That was the trend, and that's where these studies kind of came out of. So what we found is that everybody expects, hey, I'm going to take all of these victims, all of these patients who are shot, and I'm going to take them all to Truman. We have patients who go by private vehicle, Uber, PD, fire department, get these patients to the hospitals. And then what we found is that the hospital on the administrative side has this policy that says this is what we do in this instant. But the specialists, the ER attendings, myself included, had no idea what that policy was, despite me being at Truman since 2005. And so it just reiterated the importance of the disconnect between what's actually going on in the field versus what's written in a policy. The other thing that Dr. Gaddis had touched on was the care through teamwork in the EMS transport in the hospitals. That was approached because whenever we are on scene and we have a trauma, we limit the scene time to less than 10 minutes. And so what information can you gather in 10 minutes? My chief medic, Michelle Shear, is a pro at it because she's 30 years plus pre-hospital experience. She can get onto a scene, multiple car accidents, and a lot of those involve shootings too. She can step onto a scene and very quickly and concisely abbreviate that story and give me that information in the trauma bay. What we found, though, is what people were asking in the trauma bays across the board is very different. So if I bring a trauma into research, I get different questions than if I bring the trauma into KU or Children's Mercy or Truman. And so a lot of this, again, had to do with communication of information, how to make it concise in less than 30 seconds, because that's what EMS is used to. So, and then for the antibody study, with what Dr. Gaddis was saying, I just want to throw out the caveat that we understand this is all the Wild West when it comes to testing. There's no FDA regulations currently. It's all emergency waivers. And so the goal of the antibody study is truly more surveillance to see what does it look like for us here in the Midwest compared to an agency on the West Coast and then the East Coast. And so our operational change will not occur because of the antibody test. It's too premature for that. It's just beginning to ask the question of what that antibody looks like in a pre-hospital provider's realm. All right, and then my last slide, like I said, was questions, but we can save those to the end. So thank you guys for your time. We appreciate it.
Great, thank you, all three of you. That was wonderful. Wonderful. Well, we will now move on to our next speaker. So now we have the hospital perspective. So we'll be hearing from Denise Mogg, who is the Vice President of Capacity Management at St. Luke's Health System. And she'll be talking about eliminating silos, hospitals partnering with pre-hospital and post-acute safety net providers to close the gap of care for addiction and mental illness. So we're very excited to have you on, Denise. Thank you.
Hi, can you hear me okay?
Yes, we can.
Okay, give me a second. So trying to, let's see, do this. See if I can share my screen. Can you see my screen?
Yes.
Okay, good. I'm very new to Zoom, so I appreciate everybody's patience. St. Luke's doesn't allow Zoom. We have it on our home computer, so I'm on my iPad, and this is the first time I've done it because, like most, probably everybody on this call, I have been spending every waking moment in the System Incident Command Center working on COVID plans, which has been challenging and exciting and truly something different, but have learned a lot. So I appreciate this opportunity to talk about something other than COVID. As mentioned, I'm Denise Mogg, Vice President of Capacity Management, but really what I'm going to talk about is the time that I spent as the Director of Emergency Services at St. Luke's Hospital. And I started in that role in 2004 and just handed it off that role in December of 2019. And while I was in that role, I became very passionate about serving individuals who suffer from mental illness, addiction, and homelessness. So I'm going to focus on that because the process that I'm going to talk to literally is rapid cycle quality outcomes with a focus on holistic care for this patient population. Let's see if I can get that slide to change. Here we go. So the first thing that we did when we started asking ourselves the question, why is it that patients continue to come back to the department? And the answer from the staff was transportation. We set up all sorts of appointments for people. Here's your safety net provider. You want to do outpatient rehab. You want to get help. We set it all up, and then we recognized they don't have transportation. So we put into place a program to provide a bus pass, not only upon discharge from the emergency department, but also an additional bus pass to get from point A to point B to attend that appointment, be it for mental health or to have a greater assessment to see if they could receive help for their addiction. And as we worked our way through patients and began talking to them and working with our safety net providers, what we found was individuals were struggling with navigating the bus system. A lot of these individuals were homeless, and they may not be in the same shelter every night. They may not even be in a shelter. They may be on the street. And so when we gave them a bus pass, they didn't know how to get from where they were to where we made the appointment. But also, as my slide notes, time is an issue. If you don't have a watch and you don't have a calendar, how can you make an appointment that somebody has set up for you with really good intentions? So our next step was, well, how can we provide support 24/7 for transportation and maybe even short-term lodging with some help to navigate the healthcare system? You know, day to day, the healthcare system is challenging for any of us, let alone if we're homeless, we're struggling with mental illness and or addiction. So we engaged Artists Helping the Homeless, Car Wu, an individual who set up a nonprofit program, and we wrote a grant. We were able to support his programs through transportation. And initially we brought the transportation on to the emergency department at night when we had individuals who needed to go to shelters or go to a friend's house or find short-term sheltering. Carr actually expanded his services from transportation into some short-term lodging, and that was helpful as well. And while some individuals really fit into that niche, we knew that there were other individuals who did not, because as I mentioned before, we continue to do rapid cycle. So once we were placing individuals and they were no longer coming back into the emergency department, there were other individuals that rise to the top. Those that, again, have multiple visits and are very well known to us. So the next thing that we did is we were like, okay, this is like Maslow's hierarchy of need. If you don't have food and you don't have shelter and you don't have transportation, you're really not going to be successful at not only accessing healthcare, but improving your own health. So we began at St. Luke's to partner with Rediscover on a program called hospital diversion, not to be confused with ambulance diversion, which we all obsess over and talk about incessantly in the emergency department. Hospital diversion is a program set up, it is grant funded, still in place, and has care coordinators who have a very limited group of individuals that they follow. Most of those individuals are homeless and are struggling with chronic health issues, a lot of mental illness as well as addiction. And to close that loop, social work and care coordinators from the hospitals throughout the community come together once a month with representatives from Rediscover Hospital Diversion, and we talk about those patients. We talk about that continuation of care. Are we all doing the same thing? Are we all on the same page? Do we know who the care coordinators are for each individual? If we are starting to see those individuals utilize the emergency departments again in a very high rate of fashion, that usually means there's a problem, and we can call that care coordinator. And while their care coordinators are available 24/7, they're not out on the streets 24/7. So it literally becomes a limitation of services. They're limited Monday through Friday. You know, they're not working weekends and holidays to connect with individuals. They're very limited on patient placements or, you know, post-emergency department visits as it relates to rehab programs. Multiple individuals that we work with and support in emergency departments have been in every rehab program in the city for drug and alcohol abuse. And it's really challenging for those programs to continue to take individuals over and over and over, or hold a slot for them when they maybe don't engage in the program. So how can we support individuals, make sure they're ready to go into those rehab programs and get them into the next step? So we identified that as a limitation for mental health services. We really wanted to support patients who are struggling with mental illness. As we all know, the limitation on inpatient beds is significant throughout the nation as well as in our community. So the key to that is making sure that people get connected to the right services out into the community and are followed and supported. And then lastly, there's a lot of limitations on shelters. People don't understand oftentimes that to get into a shelter, you have to be rather coordinated. You have to be there by a certain time of the day to request shelter for that night. And then you have to be in that shelter by a certain time at night. They close the doors, they lock them, they don't let anybody else in for safety reasons. In addition, you can't be impaired. You cannot be inebriated or high on drugs. So to actually get into a shelter, to navigate the different food banks and all of those things really is complex. And again, we said, okay, we have this group of individuals. It's a large group that we've really helped with these services, but now we have this group that is really struggling. They almost are the highest need. They're homeless. They have addiction problems that are either manifesting some mental health issues, or they're treating their mental health with their addictions, because of the medications for mental illness can be rather challenging and have a lot of side effects. But how do we support them? How do we provide holistic care post-emergency department visit so that ambulance services aren't constantly picking them up and police aren't constantly running them, and it just becomes a revolving door? So I'm going to say it was in 2014, a large group came together in the community and conducted a community assessment, needs assessment. And what we determined and began to work on and put in play in 2016 was a facility that was available for individuals 24/7, 365 days a year. It didn't matter if they were struggling with mental illness or addiction, or if they were homeless. They had a place to go to be assessed for 24 hours and then connected into those things that we all know are vital, which is shelter, food, support, both for their physical and mental well-being. So we really felt like it was closing the loop. This program is called the Kansas City Assessment and Triage Center, and it's been rather successful. So for us at St. Luke's Hospital, with this rapid cycle, we continue to look at what do we need to do, how do we need to do the assessments, what do we need to put in place to improve, how do we work with the police, EMS, safety net providers, but how do we open this net up wide? Last year, I think it was last year, everything kind of goes fast, but last year we decided that we should truly be assessing every patient for needs for food, shelter, and transportation within 24 hours of presenting to the emergency department. So when patients present to the ER, they all get asked the same questions about food, shelter, and transportation, and any needs that they may have should they be discharged. We then have social workers that are in our emergency departments 24/7, and they develop a safe discharge plan when we identify individuals who have needs in those specific areas. We watch our data very closely. We try to identify individuals who maybe are starting to cycle back through the emergency department, and we go into and work collectively through electronic medical records to connect them back into the community when we see that they're struggling. So for the hospitals, it's really about being connected to every level and making sure that we have open communication. And I can say that it's improved greatly from when I started my career in the emergency department as a leader. You know, we would treat patients and we would discharge and hope for the best. And that is not the case anymore. They can't navigate this system. So hoping for the best doesn't really work. We must partner and connect and develop those relationships to provide the best care for our patients.
Thank you very much, Denise.
Well, you're welcome.
This is Carol Decker. I'm one of the facilitators along with Stacy Farr and Dr. John Spurtis. It's time now for the question and answers. So if all of the speakers would open their chat feature, you'll identify some questions that have been asked by our participants. So we can address these, and then we can find out if there are anybody that wants to like raise their hand and unmute themselves and ask a question. So Sergeant Hess, I see one there with your name on it. Would you mind taking that first question?
Sure. So looking at the first question there, there are a lot of high utilizers in Kansas City. And part of the problem, and I think we've talked about it, is that there was a lot of silo work going on. You know, some of the hospitals had identified some of their people, the police identified theirs, EMS. And so with the hospital diversion that Denise was talking about, we've really kind of pared down and tried to get a central list that we could coordinate with and work on partnering, working together on you know, affecting this group, and getting rid of those silos is a huge thing. We have a seat with them at the hospital diversion meetings. We meet monthly with Rediscover and talk about the folks that we want to work with and power down that group, and then work with the crisis center. And hopefully there'll be even some more advancements with the health department and some of the other computer technology out there to identify them.
Thank you. Thank you.
So I will piggyback on to what Sergeant Hess is talking about. So Sergeant Hess, Denise, and myself are all on that board. So we actually, pre-corona, have been able to interact quite frequently when it comes to the high utilizers. What we identified on the EMS side, the 911 side, is if you call 911, the majority of the time you are undomiciled, meaning homeless. This can be in any region. It can be up north, down south, east to west. These patients go all over the city. They're in every single zip code. The biggest concerns that people call 911 for in the high utilizer list have to do with mental health and sobriety or intoxication. And so that has been the target focus. So the first focus of the city's high utilizer group was housing. Sergeant Hess and myself were involved in that. This was all before Corona. And then connecting these people with case managers, social workers, and inpatient or outpatient sobriety and or mental health. So KCATC has been a huge factor, huge player in that, but it's been every hospital involved in that conversation as well, including St. Luke's, Research, KU.
Thank you. Thanks for chiming in there, Erica. We appreciate it. Jonathan, I see there was one, maybe the first one that was asked. What reasons do ER docs give for not using Narcan?
Yeah, so I think I'll just make some clarifications there. It's not Narcan that's the problem. Every emergency department, EMS provider, even police officers, I think to some extent now, are using Narcan. So Narcan is used for the reversal of opioid overdose, right? So everybody's using that to save lives. And we provide that Narcan as well to community members, to our clients. And that's a medication that we have. You know, I got cases of it in my office right now. My coaches take it by the case and they hand it out to everybody. So we are trying to get that out in the community as much as possible as well. Medication that oftentimes doesn't get prescribed at the hospital is what we might, Suboxone. I refer to it as MAT, depending on who you talk to. Medication for addiction treatment, medicated assisted treatment, depending on how it goes. But yes, Suboxone, buprenorphine, naltrexone, Vivitrol, those are all kind of the same. They fall into that category of MAT. So that's what's not being prescribed at ED. The reason why that's not prescribed at the ED oftentimes is because it's such a short amount of time I think they're at the hospital. So doctors maybe don't have really a full good history on a client. It also takes a waiver, a special waiver by the federal government. They have to go through a special training. I don't think it's a hard training. It's just doctors that might not be on their priority list. They got a billion other things they have to do. And so not every doctor is waivered. And even the doctors that are waivered, again, just are they in the hospital when it happens? Are they the doctor attending that patient? Do they feel comfortable giving the client a dose or even a prescription for that matter? A lot of times ER doctors aren't necessarily providing ongoing maintenance, medication like that. So they're just really trying to stabilize the patient and move them to the next thing. That's where Epic can come in. We can provide that bridge to their next support step. So the last speaker we had was speaking a lot of the care coordination that went along and the emergency department to connect patients, knowing that there were about 20 other things probably more important to that patient than just their medical service that they were getting at that moment. And so Epic engages care coordination for housing, for medication-assisted treatment outside of the hospital. And we oftentimes, for MAT connection, again, that Suboxone, Vivitrol, those types of things, usually Suboxone is probably 90% of what we do, some methadone, but not much. But we're getting people connected within 24 hours. So if we get a call, we go to the hospital, or in this case, we're doing a lot of phone intakes because we're not going to the hospital. We're trying not to interrupt their services too much right now. But even still, we're getting clients within 24 hours from the hospital within the next day. We have them in front of another provider that can provide long-term services for MAT. So just that's the clarification there. Yes, they provide Narcan all day long. MAT is the other thing. And we have lots of providers that are doing that we care coordinate that with outside of the ED. So or first responders, et cetera.
As an ER doctor at Truman, we've all gone through this training, and just what he is talking about, it's not Narcan that's necessarily the issue. It's more of the chronic medications. Because again, we are just ER docs. I'm just seeing you in your time of crisis. I'm not following you at all. Right. So Suboxone, for instance, has an opioid agonist in it and an antagonist. So it's not clean like Narcan is. So there's a lot of side effects that come with that and a lot of follow-up potentially, just depending on the situation. Pricing is another big issue with the majority of our patients if we can't get them free medications. And our patient population here in Jackson County is much different than when I practiced in St. Louis. St. Louis is a pretty clean opioid overdose almost 100% of the time. In Kansas City, our patients and citizens really like mixed bags. They like uppers and downers. They like PCP, cocaine. And so a Narcan effect is going to be a little bit different in our patient population in Kansas City, Missouri than it is in St. Louis, Missouri. And so we studied that time and time again. If you look at Kansas City, Jackson County numbers, yes, our opioid use is up, but that's because our population compared to the other cities in the state is big. So in Jackson County Central, though, our issue really is a mixed bag, not necessarily just the opioids.
So I wanted to jump in really quick and go back to the high utilizers. I just pulled up a data set from our last study that we did on our high utilizers, and to give you all just an idea of the gravity and the cost that this costs us as a society. We have a frequent user or a high utilizer who showed up in the ED in 1 year 218 times. That's tremendous. Our next one was 102. Next to that, we went all the way down. We had our top 10 high utilizers. Even we were at 27 for our top 10. So that gives you an idea of the number of visits that these individuals take and the cost that takes to Jackson County, especially since a lot of these people are undomiciled. Yeah.
Well, thank you. Thank you. It's nice to see one speaker answer along with another speaker. So it's really nice to see that this kind of the collaboration, which goes into another question that John Spurtis asked. We've heard of the critical role of first responders in initiating treatment for critical illnesses like heart attacks, strokes, and sepsis. How have the participants collaborated to optimize treatment for these emergencies? And we've heard some of that. Is it usually, specific on a certain disease or is it a social determinant, or how do you pick?
So a lot of this goes into accreditation and certification. So that is state-based. So for St. Luke's Hospital, where Denise is, they are a trauma center, stroke center, and a STEMI center, which is the heart attack center. And so the states basically tell us who has these accreditations, and they have certain standards that they have to upkeep to remain accredited as a level 1 trauma center, primary stroke center, comprehensive stroke center, whatever it may be. And then on the EMS side, that is communicated with us. So if you get your accreditation, then we know right up front, hey, if I've got a major trauma, this is where they're going. This is who I choose from. The protocols and how that is set up is done on a regional basis. And so here in the region, I'm with Kansas City, Missouri. So when I make a protocol change, I have to go through multiple committees. Those committees involve from all of the level 1 trauma centers, stroke centers, STEMI centers. So a big chunk of my role when I transitioned into this position 2 years ago was stroke and getting stroke patients to the appropriate center. Can that be a comprehensive stroke center or a primary or a secondary stroke center? And what do their outcomes look like? And so it definitely is, it's dynamic. There's certain areas where they gain accreditation or they lose it. And so we have to keep up to date with that. But it's also in our region quite static as well. You pretty much know who the stroke centers are, who the STEMI centers are, who the trauma centers are. And so if you are looking at affecting trauma patients overall, I go directly to those trauma centers and work directly with those trauma surgeons. There's also national protocols that we use through NASIMSO. So all of our protocols here in Kansas City, Missouri are based on the national data aggregation of all of the individual states as well. I think that kind of answers it.
I think you did a nice job answering it, Dr. Carney. And, to boot, if there's a change, we all work very closely through Mid-America Regional Council. So there are many subcommittees, one specifically on time critical diagnosis that all of us set on, pre-hospital, hospital, and specialists. And we work not only on the routing criteria, but the treatment out on the street coming in. Time does make a difference. And then that is also where we set up our EM system, which is electronic and allows dispatchers to talk rapidly to those folks who are on the ambulance, because that's key. You can't haul somebody to a hospital to only find out that they're closed because their CT scan's down. So the coordination between pre-hospital and hospital is pretty tight in the city.
Especially here in Kansas City.
Mm-hmm.
I've worked elsewhere, and I can let you guys know that our region is very used to communicating. And that brings me to Corona, having a pandemic in the midst of this. It's really proven how strong our previous relationships have been. So if I ever had an issue, I could just call Denise, or if my providers were causing an issue, or same with the patient. And so feeling very blessed to be a Kansas City citizen in the midst of the pandemic with that previous relationship that we've developed. So
I agree.
So there's another question that's shown up that says, are there any similar first responder coordinating efforts for people with cognitive impairments? For example, people with dementia who are frequent flyers.
So that goes into guardianship, which is the question. We do have a city mental health support, but the true guardianship of a patient is extremely difficult to prove. So because somebody chooses, for instance, if alcohol is the drug of choice, if somebody's choosing to drink, does that mean that me as a physician can take away your rights to autonomy and make you my guardian? And so what we see specifically in our patients is the cognitive dysfunction associated with that intoxication and that lifestyle. And so it's a huge challenge for us here in Kansas City. And Sergeant Hess and his crews can't go around and arrest every single time so-and-so has been intoxicated or whatever it may be. So it really relies on our relationship with the state and the ability for us to prove that this high utilizer is endangering their own life and potentially others, but this judge is just meeting that person for the first time. So try to paint here, take away Jane Smith's competency, make her have a guardian in a matter of minutes to a judge who has never met her before is actually quite a big ask. And it's not as straightforward as a minor or something like that. A minor is way easier than somebody who's an adult that's competent in the state of Missouri. Even if they don't have capacity, they have competence, so.
Well, some of these questions seem kind of benign, but boy, they're really complicated and complex, aren't they? So do you have, Sergeant Hess, do you have social workers on your team? You know, with some of the things that Dr. Carney's talking about, social workers kind of deal with every day.
Yeah, and I'd like to kind of first piggyback off of Dr. Carney on talking about the people with cognitive impairments. So we do work with Department of Health and Senior Services, probate court. Judge Stiles actually does some of the training with us on CIT and the other commissioners. So we do have a first-hand relationship with them. KCRO for some of the other cognitive autism and stuff like that. And we work with a lot of the different group homes, so in the Alzheimer's Association. So there is some stuff that's going on the back end on that, on dealing with the cognitive. Now let me jump in with the social workers. It's very exciting that we do have social workers on our team. Actually, we have availability of 2 different levels. So social workers from each of the community centers, such as I talked about Tri-County, TMC, Rediscover, they go out with us and go out with us weekly. You know, we have set time that we go out and do follow-up visits with them. We discuss plan of action, how to get the person into services, and really the team is just there on that. So we work firsthand with them. I said on a weekly basis, they're really embedded with us. And then at a division level, there's a social worker at each of the division stations in Kansas City, Missouri. And so what they do is something a little more low rent on the, they're more concerned with some of the environmental things going on, maybe low-level dementia starting up, working with neighbors that are in disagreements, youth, small crimes, and stuff like that. So we do a lot of referrals with them on that level as well and work with them, and they're able to also engage with us and work with us. So, yeah, we are fully integrated with social workers, and it's kind of exciting. I never thought I would see that in law enforcement when I started.
Well, thank you. Thank you very much. Well, Stacy, do you want to take more questions, or do you want to kind of wrap this up, or does any panel member have anything else they would like to add?
I just threw my contact information there in the chat section. So if anybody has any further questions after the meeting, or it's wonderful hearing from all of our speakers today. If you guys have questions, or if I can assist you all in any way, shape, or form, I'd love to hear from you.
I would just like to say, you know, it is so inspiring to see all the wonderful work you're all doing, and how integrated a lot of your efforts are. It just makes me really proud to live in Kansas City, and it's really wonderful. And the presentations were so good and so professional. Thank you so much for sharing it with all of us. Really, really appreciate that.
Thank you.
Yes. Any lingering, burning questions that anyone wants to ask before we jump off? I just want to echo and thank everyone who was able to join today. I want to thank everyone who's working out there as first responders and police, and anyone working as you know, the first point of care for some of these patients. So thank you. And we look forward to seeing you all next month when we talk about how we basically adapted to COVID, what worked and what didn't in terms of healthcare delivery. So thank you all. And thanks again to our speakers. So